The Pat Miller Program from the Windows, Doors, and More Studios on WOWO, 1190 AM, 107.5 FM. Depend on it.
A lot of things to cover in the balance of the program today, including Indiana Senate leader David Long, President Pro Tem of the Indiana Senate, announcing that he, in fact, is going to retire this fall. He'll be on the program tomorrow. We'll talk about it a little bit today, and a lot of other things. But probably nothing grabs the attention of people more than the costs of health care. And as you break that down, one of the things that's always the big drivers of the cost of health care is the cost of prescription drugs. Seth Denson is the president and co-founder of GDP Advisors. You say, what's that? Well, he's a health insurance strategist. He's becoming very popular with the media because he understands the thinking about everything involved with prescription drugs and the burden that becomes for some people. So let's talk to him real quick. Seth, good afternoon. Welcome to the Pat Miller Program. Hi.
Hey, good afternoon, Pat. Thanks for having me on.
You bet, absolutely. Well, I know the White House last week, toward the end of the week, released that white paper where they're proposing some policies to try to do something about high prescription drug prices. Seth, first of all, on some drugs, they really are high, aren't they?
Oh, my goodness. Yeah. I mean, listen, healthcare expenditures are rising at an astronomical rate, and the advancement of prescription drugs within the marketplace are going up higher than any other aspect within the healthcare markets.
Well, I'm sitting here looking at a list of the most expensive drugs. I'm looking at a hepatitis C drug, Harvoni. Am I pronouncing that correct?
You are, yeah.
I'm looking at $87,800.
Yeah.
That's for how much?
Usually it doesn't. Usually folks that have to take that drug have to take it more than once.
Oh boy!
So we're seeing the average treatment on hepatitis C to be around $150,000 on average. Now, let's put somewhat of a silver lining around this, and obviously the cost is absolutely a driver of the discussion. But fortunately, and Harvoni is a great example, we're manufacturing drugs now that are actually curing diseases.
Yeah, we are fixing problems.
There is a positive here, but you're absolutely right. The costs associated with that are just astronomical, and for many are just unsustainable.
I mean, there've got to be some people that, and hopefully a lot of people that are on this have prescription drug coverage, but not everybody will. This is, you're mortgaging the house here.
You really are, and unfortunately, that's really what health insurance has become. It's just healthcare financing, and when we're talking to our clients and people that are asking our advice and opinion, it's one of those things that we talk about all the time. You mentioned it. Hopefully, these people do have good health insurance coverage, but the reality is that when we see expenditures like this, that makes its way back around the barn and to you eventually by way of health insurance premium increases.
Well, I've got to tell you, I sold health insurance. In fact, I'm still licensed to do it, and I do it on the edges. It's nowhere near a large part of my business. I do a lot of life and long-term care and annuities and financial services and that kind of thing. But I remember all the way back in '93 when I first started selling healthcare, usually your mortgage was like your big ticket item, followed by your car, and then sometimes followed by education. But for a lot of people right now, healthcare is their largest expenditure for their family every month. And drug prices like this, this doesn't help, Seth.
That's right, and it's unfortunate. I'm in the same position as most others. I've got a wife and 2 young children, and the expenditures for our family health care plan are nearing $1,500 a month. And so, when we look at that as a we'll call it a line item in our family profit loss statement, it's rather significant, and we're on a plan that doesn't provide really any access to coverage until we have something catastrophic occur. So, to get a plan that's going to provide lower access to care, lower cost access to care, is going to cost a significant amount of money, and these prescription drugs are a big driver of that.
Yeah, but I'm sitting here looking at the 5 most expensive drugs in the country. Harvoni is the highest at $87,800. The 5th highest drug is $51,700. And then, of course, some of them come down from there. I'm on some drugs because after my kidney transplant, I contracted a virus. And so I went on a Valsite, which is kind of a chemo level antiviral, and that crazy thing is a few thousand a month. So I mean, these are real numbers that are hitting real people. Now, the president's plan with the White House coming out with these policies, where the president, and he kind of campaigned on this stuff, saying we have to do something about drug costs. Is he right when he said that we had to do something with the price of drugs because a lot of other countries are putting out drugs or they're doing it in other countries for a lot less money, and we're basically picking up the burden of paying for drug costs around the world, and he says this has got to stop. Is he right?
You know, he's absolutely right. The question is, where are the details on how you can actually make that change? I mean, you know, there are certain aspects that the federal government could do internally here in the United States to impact some change on how they procure drugs. You know, over 40% of Americans are getting their drugs through the Medicare and Medicaid programs, and the way that the federal government procures drugs through that program is significantly inefficient. As far as foreign markets, you know, the president's right, and it was detailed in his report as well, that, you know, American citizens are bearing the burden of 70% of the profits associated in the pharmaceutical industry. And the reason for that is because of our free economic climate, which I'm a big fan of, obviously, being a capitalist. But the hurdle with that is, in other non-capitalistic ecosystems, right, we don't have the leverage to require those federal governments to abide by certain structures. And so, unfortunately, what's happening is the American people are paying for the research and development. By the way, the average development cost of a drug in the United States right now is over $2.6 billion with a B dollars. And so the United States citizen is paying for that, and the pharmaceutical companies are actually okay with that, unfortunately, because what they're able to do is still sell that drug once it's been developed in other countries. So Americans are paying for bottom line growth, and other countries are getting to pay for top line growth, and it's just unfortunately something that, unless we see significant policy change, which has a whole slew of implications, I don't know that is the way that we're going to be able to curb anything.
Well, I'm talking to you from Fort Wayne, Indiana. Right down the road about 2 hours is Indianapolis, which is the home to Eli Lilly. And I talked to somebody from Eli Lilly a couple of years ago. One of the things that he said, the cost of producing a brand new drug, one of the reasons it's so high, and I'm going to throw this out and see if it makes sense to you. He says the reason it's so high, we have to recoup our cost for developing that drug in a rather short period of time, because in the 7th year, they can start selling generics of our drug, and then nobody's going to want to buy the real thing after that point because the generic will be so much less. So we have to make it. So have we caused the timeline for them to recoup their money to be shorter, and so the prices shoot up?
Yeah, I think there's a two-pronged issue here. One, it is. I mean, there is a shorter time frame for them to recoup those dollars. Although, you know, the standard patent is 20 years on prescription drugs, but that starts to be released at an earlier time, and that patent starts at an earlier time as well. But the other hurdle is it just takes too long to get through the overall approval process through the FDA. And so by the time it takes over 8 years on average to get through that. So by the time you're through that 8 years, you're already 8 years into your patent on a drug. And so it does significantly shorten the window for somebody to return profits, and those profits are required because of the significant cost associated with the tests and development and the process of getting it through federal approval.
You know, one of the ways that we've talked about keeping the cost of health care down is to allow health care companies to sell protection across state lines. If I've got 5 policies that my company puts out and I sell it in Indiana, but I'm also selling it in Ohio and I'm also selling it in Texas, I've got to get it certified and everything in each state. What I thought was interesting and what I've read, explain this to me, this paper that came out of the White House, one of the things that they're proposing is up to 5 states could band together to negotiate Medicaid drug prices so that it would reduce it for their 5 states, and then I guess ostensibly another 5 states would get together and then another 5. Is this really what they're proposing? And in your view, would this really work?
You know, unfortunately, this was a talking point surrounding the document, but the document was very limited on details of that. As we reviewed it, and we reviewed it extensively in our office, we were really trying to dive into that component. I think it could work. I think that if that is the part of the overall proposed plan by the president, it absolutely could work. Listen, it works for every other facet of economics, right? Is that if I buy more, I can drive down the cost. The issue with Medicaid and Medicare as it's structured now is there's actually negative incentives for those costs to go up. For example, if I'm a doctor under Medicare, I'm paid a commission based on the prescriptions that I provide.
Right.
And so, there's not an incentive for me to drive down the cost or prescribe a lower-cost medication when I'm paid a percentage of the overall medication as an incentive. And so, and then in Medicaid, there's a number of ways by which drugs are discounted and required to be sold that actually keep an artificial inflated price to the overall drug. So I think any way that we can restructure and allow states to come together to negotiate, and what I was hoping to read in the report that unfortunately wasn't there, was that the government was going to get involved in their own federal programs and do direct negotiations. Unfortunately, that wasn't in the report. I'm hoping it's still on the table, and it'll be something that comes out in the near future.
Would direct negotiations by the government with drug companies to try and negotiate prices, is that something that you think would come up just short of government price fixing?
Listen, we do start to go down a potential slippery slope, but specifically the government price fixing would be setting a specific drug for the masses. And what I'm talking about here is just the government saying, hey, we're having to procure these drugs for Medicare and Medicaid patients. We're not paying these prices that you're offering us now. Mm-hmm. So right now, the price structure is based on an overall discount on the average sales price of the drug. And so rather than so when you say a discount, well, a discount off of what, right? And so our ability to go in and procure specific drugs that are higher utilized by Medicare and Medicaid patients, driving that cost down. Again, this isn't going to impact the overall cost of drugs to the average consumer so much as it's going to lower the overall deficit process that the government's going through in these Medicare and Medicaid programs and drive down the cost for those users within those programs as well.
Well, and they may be driving themselves closer and closer to that kind of a suggested setup because if they don't do something as by their own admission to Medicare and Medicaid, it's going to be pretty hard to get the overall debt of the country down. So one thing might push another. Seth, before I let you go, somebody sent me a text on our 46862 line, and this goes back to something you and I were talking about a couple of minutes ago. The caller is asking this: are you suggesting that a single-payer system would make it impossible to develop new drugs? Might not make it impossible, might make it a little tougher, wouldn't it?
Yeah, listen, some of the greatest economic advances in the world outside of healthcare and inside of healthcare have been because private industry steps up and sees the potential reward for that. So with a government system, a single-payer type system, the ability to drive innovation through the opportunity that capitalism provides and a free market system provides, I think, would be dwarfed. So I'm not a fan of a single-payer system for purposes of innovation. I fear that if we did that, look at the rest of the world that is on single-payer. They look to the United States for innovation and advancement.
Yeah, exactly right. His name is Seth Denson. He's with GDP Advisors. In fact, if you'd like to find out more about him and our conversation today, go to GDP Advisors. That's GDPadvisors.com. Seth, we're going to put this interview up on our website, and we're also going to put a link so people can find you more easily. I'm sure we'll talk again because healthcare is not going off the table very soon, and certainly not drug costs. Seth, for your time today, thank you so very much. We appreciate it, sir.
Hey, thanks for having me on.
You bet. Seth Denson talking to us about the cost of drug care.